Hello. Hello.
Hello, ma'am.
Can we start the class now?
Yes, ma'am. One second.
Yeah. Start presenting now. Who is the presenter today?
Hello, ma'am. Hello, ma'am.
Yes, yes, ma.
I'm Ashwin, ma'am. I'm presenting today, ma'am.
Okay, ma. Start presenting.
Okay. 74-year-old male, Mr. Siva from Tiruvanmiyur came with chief complaints of breathlessness for the past 6 months, palpitations for the past 1 month, chest pain for the past 1 week. Uh, on elaborating the chief complaint, history of presenting illness, the patient was apparently normal 6 months back, after which he developed dyspnea, which was for the past 6 months, gradual in onset, progressive in nature, which is of grade 2 type, and it aggravated on exertion and relieved on rest. Uh, he has no history of paroxysmal nocturnal dyspnea, orthopnea, trypopnea, and platypnea. Palpitations are for the past 1 month, which is
What?
regular
Yeah.
and
What was he able to do, ma?
gradual in.
Re regarding breathlessness, what he was able to do and what he was not able to do. You told me it is in grade 2, no?
Yes, ma'am.
Uh, what he was. Can you
Ma'am,
tell me the grades?
grade 2 is my uh, ma'am, grade 0 is without any limitations, ma'am. Without any
Okay.
limitations to his physical activities. Grade
Any
1 is
physical activity.
grade 1 is ordinary physical activity cause fatigue and palpitations. Then class 3 is less than ordinary physical activity cause fatigue, and class 4 is even at rest gets fatigue or palpitations.
Okay. He doesn't have orthopnea.
Uh, no, ma'am.
PND also he doesn't have.
No,
Okay.
ma'am.
Okay. What is trypopnea and platypnea, ma?
Trypopnea is when he's uh, when he sleeps on sleeps on one lateral side, uh, while lying on one side, he gets dyspnea, but while lying on the other side, that is the lateral recumbent position, he won't get that dyspnea.
Where do you get it?
Ma'am,
Where do you get the symptom of trypopnea? In which clinical
trypopnea, ma'am.
condition? Yeah.
From congestive heart failure.
Congenital?
Ma'am, congestive heart failure.
Okay. Then any respiratory conditions?
Pleural effusion, ma'am.
Yes,
Refusion? Okay. Then platypnea?
platypnea.
What is platypnea and which clinical condition
Shortness
causes?
of breath, ma'am. That is
Yes. Yeah.
platypnea is breathlessness due to when he's standing or like sitting, ma'am, and it
Mm.
improves when he's in supine position.
Mm. Cause?
Can I proceed?
Yeah. What is the clinical condition causing it, ma?
Cause, ma'am, in intrapulmonary shunts, platypnea occurs.
Mm. Any tumorous condition?
Clinical condition.
Left atrial myxomas can cause platypnea. The myxoma can cause
Hepato
mm,
tumorous condition. Hepatopulmonary
AV.
hepatopulmonary syndrome.
Oh, yes. And left atrial myxomas can cause. Okay, ma, proceed.
Okay. Palpitations for the past 1 month, which is regular and gradual in onset. It's a few minutes duration, not paroxysmal, and it aggravated on exertion and relieved by rest, associated with chest pain.
Say when you
Chest pain is for the
talk
past
about
1 week,
one, one
which is
minute, 1 minute.
gradual in onset.
Regarding palpitation, so you say
Yes, ma'am.
Palpitations are not continuously present. It's only present for few minutes. So what else you want to add to it?
Yes, ma'am.
When all he gets palpitations. What else you want to add in history? You have to ask about the precipitating factors. What makes or what situations he's getting palpitation? What precipitates his palpitation? You have told that it is not present.
Ma'am, exertion. On exertion.
It's got precipitated in
Ma'am.
exertion and
No, ma'am.
aggravated.
I stated that it gets
Okay.
aggravated on exertion, ma'am,
So which means it's been present every
and relieved
throughout
by
the day,
rest.
complete relief by test. Okay. So precipitation is also by exertion. You want to get
Yes, ma'am.
tell that it's precipitated and
Exertion.
aggravated by precipitation and aggravation is different. No. So onset is what makes it
Okay, ma'am.
uh, in what condition it gets manifested. Okay.
Okay, ma'am.
Why do you say it's not paroxysmal? How do you say?
Ma'am, uh,
It is episodic, and that's why.
It is episodic, right?
Yes, ma'am.
Hmm. So where do you get paroxysmal palpitations?
Atrial fibrillation could have it, no?
Yeah, atrial fibrillation you get. Okay. Then okay,
Ectopic.
ma'am. You,
ma'am,
ectopics.
in PSVT.
Okay. Sometimes you don't have any specific precipitating factors or aggravating factors. So it is very sudden in onset sometimes palpitations. You need not have any even at rest. These types of palpitations appear without any provoking factors or aggravating
Okay.
factors. Okay. Then you can
Okay,
proceed.
ma'am.
Yeah.
Chest pain for the past 1 week, which is gradual in onset, and it is substernal, which is squeezing type, and it is intermittent, radiating towards left shoulder, which gets aggravated on exertion and relieved by rest. And it is also associated with palpitations and not associated with food intake.
Okay. Why do you want to ask about food
Uh,
intake? Chest pain with food intake.
Due to peptic ulcer, GERD,
Mm. Or esophageal spasms that can also
esophageal spasms.
that can also mimic your angina. So here you say about a
Okay,
typical angina, which is
okay,
substernal location, squeezing and radiating. It has specific aggravating factors and relieving factors. Okay.
okay.
Then
Yep. No history of loss of consciousness, no
okay.
history of cough with expectoration, no
Mm.
history of pedal edema, no history of abdominal distension, no history of
Mm.
dyspepsia, no history of right hypochondrial pain, no history of puffiness of face, and no history of fever with sore throat, no history of joint pains, no history of involuntary movements, no history of skin manifestation like rash and nodules, and no history of voice change or dysphagia, no history of oliguria, no history of cyanotic episodes, clotting, no history of recurrent respiratory tract infections, and no history of hemoptysis.
Okay. So how all this negative history is significant here? Fever with throat, joint pains.
Ma'am?
I mean, why do you want to roll out all this negative history, ma? This all these negative histories. What all conditions you get? Fever, sore throat, joint pains,
Uh,
involuntary movements.
Fever.
Is it relevant to your case?
Yes, ma'am. Because
Mm.
we need to
How it
rule
is
out
relevant?
fever.
Mm.
Yes, ma'am. Because in rheumatic heart fever.
Okay. He is 70 years, no?
Yes, ma'am. 74 years.
Mm. This fever, sore throat, joint pain, rheumatic fever. History will be significant when you get a young individual or a middle-aged individual. Mm,
Okay.
okay. Then the skin manifestations like rash and mollules also goes with rheumatic fever. Okay. Then what else?
Okay. Then
Why
no
do you
history
want
of
to ask about cyanotic episodes, squatting? If he is going to have a
ma'am.
cardiac issue, if why you want to ask about the cyanotic episodes and squatting here, ma?
Any other cardiac issues?
A person with congenital heart disease would have been manifested earlier, not in a case of 70-year male.
Okay, ma'am.
I think you can better avoid it. Okay.
Okay.
Okay, ma, proceed.
Past history, no history of similar episodes in the past, no history of rheumatic fever, no history
Okay.
of hypertension, diabetes mellitus, TB, sexually transmitted diseases, previous surgeries, and thyrotoxicosis, no history of chronic respiratory tract infections and cyanotic spells, no history of chronic fever, and family history, no history of hypertension or diabetes mellitus in family members, no relevant family history, and
Okay. So why
personal
you want
history.
to rule out about sexually transmitted history? The sexually transmitted
Ma'am,
diseases in his past history?
syphilis.
Mm.
Syphilis can also cause aortic regurgitation.
Okay. Then thyrotoxicosis,
And,
history of previous surgeries.
chance of any infection
Mm.
may lead to infective
Thyrotoxicosis.
endocarditis. Thyrotoxicosis.
Ma'am, it could
I don't
worsen
know.
situation, worsen the disease condition.
Because thyrotoxicosis causes
Hyperkinetic, hyperkinetic.
hyperdynamic, yeah. They cause tachycardia and hyperdynamic circulation, which can cause a failure in already failing heart. Can precipitate a cardiac failure. So you want to rule out thyrotoxicosis. Then, okay, cyanotic spell you told, congenital heart disease, chronic fever. Why do you want to ask that history? Rheumatological illness can cause low-grade chronic fever.
Okay.
What are the conditions you are worried about, especially as in your case, case of rheumatoid arthritis or ankylosing spondylitis
Yes.
can be there. So you want to rule out
Okay.
that also in your past history. So
Okay.
then relevant family history. How family
Family
history
history.
is relevant
Yes, ma'am.
in a cardiac case. How it is relevant for? So we ask about the inherited
Any congenital
congenital heart disease or inherited, whatever it is.
inherited disease.
Mm, okay,
Oh, okay.
then proceed.
Personal history, not a non-smoker or not a known
Not a
smoker
non-smoker,
or
alcoholic.
alcoholic. No history of drug abuse. Normal bladder and bowel habits.
Okay.
And
You can add on the diet history also. A word on a
diet
diet
is
also.
okay.
Yeah, either it's a vegetarian diet or a
Okay,
mixed
ma'am.
diet. can add a note on it. This is
Okay. Summary, Mr. Siva, a 74-year-old male, came with chief complaints of dyspnea and exertion for past 6 months, palpitations for past 1 month, chest pain for past 1 week, probable system involved CVS. Disease is probably an acquired heart disease involving the left side. Probable valve involved is aortic valve, and there are no symptoms of left ventricular failure.
okay.
In
I just
general
asked.
examination,
I need to yeah. Few corrections here. From this vague history, so we have only three clinical findings. No, so you need not
yes,
localize
ma'am.
this lesion to aortic valve and others. So you need not
Okay, ma'am.
localize. Okay, but only history is there. So this
Okay,
history,
ma'am.
with history, actually valvular diseases cannot be narrowed down. So I just, it's better.
Okay, ma'am. I'll avoid it.
Yeah, it's better you say,
It's better to
uh,
avoid it.
yeah, probable system involved is a cardiovascular system. I want to examine
Okay,
further. Okay, that will be better thing. So
okay,
left-sided valve, aortic valve, ethanol. I think it's better to you avoid them. Maybe you can add this.
okay,
There's no symptoms of failure. Failure symptoms. There are no symptoms of failure or
left
infective
ventricular.
infective endocarditis that you can add
Okay, ma'am.
because it doesn't have any fever, other things. No, so you can add that things, but not you can't narrow down to the only to the left side of the heart and then the aortic valve. Okay.
Okay, ma'am.
Mostly stenotic lesions, how it will present? It's going to be a stenotic lesion.
Stenotic lesions.
Syncope.
Syncope will be there. And mostly all these will be very much exertional. So it's exertional angina, exertional breathlessness, and exertional syncope.
Okay, ma'am.
Obstructive lesions can be there. Okay.
Then
Proceed.
general examination. General examination. A patient is conscious, comfortable, oriented to time, place, and person, moderately built and moderately nourished, no pallor, no icterus, no cyanosis, no clubbing, no generalized lymphadenopathy, and no pedal edema. And vitals, pulse rate is 100 beats per minute, which is regular, and it is of high volume and collapsing. All peripheral pulses are felt. No radio femoral delay, locomotor brachii present, vessel wall sclerotic.
Okay. He is actually he has tachycardia.
Yes, ma'am.
Okay. With regular
Regular and high volume.
high volume pulse that is collapsing in nature.
Collapsing. Yes, ma'am.
Okay. What is that called?
And uh, collapse. Water hammer pulse.
Okay. Okay. Then this peripheral pulses are felt everywhere you said. So this is basically a hyperdynamic
Hyperdynamic
circulation. Yeah.
condition. Yes,
Condition, and that all the peripheral pulses will be pounding in nature, especially your femorals. When
okay.
you I mean even palpate femoral, it will be a pounding in nature. And what else? You have committed like locomotor brachii is present. What is that? How do you examine it?
And uh, locomotor brachii.
Yeah.
In case of severe aortic regurgitation, uh, it is like prominent pulsation in the tortuous brachial artery.
Okay.
It's usually seen in aortic regurgitation.
Okay. What else? Where else can you find? Even in a elder age, like the person you have presenting with
Yes,
an
ma'am.
old age, atherosclerotic degeneration, such a
Okay.
finding will you can see. Where will you see this brachial artery? Medial, lateral.
Me- medial, ma'am.
Okay. So this can also be seen in a atherosclerotic. Yes, as you have told, the vessel walls are sclerotic.
Yes,
Okay.
ma'am.
So you need to have some other findings to cause to say to justify it is only a this is because of aortic incompetence. What else? Yeah. What else medical signs you will find in the patient
Other
to
peripheral
say it is
signs.
just it's not just because of atherosclerosis. It's because of aortic incompetence.
Uh, Other signs, ma'am.
Hmm.
Um, uh, Gerard sign.
Okay.
Ma'am, Gerard sign pulsation in spleen, ma'am.
Can you go from like in a regular fashion from
Regular, yes, ma'am.
yeah from head to
Landolfi sign.
uh,
Change in pupil size with heartbeat, ma'am.
okay.
Then Muller sign, uvula
Even
pulsation, ma'am.
even before that lighthouse sign is there. Lighthouse and all.
Lighthouse. Ah, lighthouse sign.
Hmm.
Yes,
What
ma'am.
is that?
It is blanching and flushing of the forehead, ma'am.
Okay.
Yes, ma'am.
Then
Then Muller sign, ma'am. Uvula pulsation.
okay.
Then Becker sign, retinal artery pulsations.
Hmm. Okay.
Then Rosenbach sign, liver pulsation.
Something like carotids.
Carotid, Corrigan sign.
Hmm. Okay.
Then Hill sign. See,
Hill sign. What is hill sign?
um, difference in the upper limb and
Ah, that
lower
that
limb.
comes in BP, not in this thing. No.
Oh, okay, ma'am. Okay, ma'am.
Uh, that we have to measure in the BP. Here I'm
Okay,
just
ma'am.
asking your visible
Pulsation.
signs for yeah
Okay, ma'am.
carotids. Okay. Then
And then
hmm,
uh, that's all.
Rosenbach, Gerald's.
Rosenbach, yes, ma'am. Liver pulsation,
Okay. Okay. Lower down.
ma'am.
Hmm. Then
Then
what do you see in femorals?
femoral, pistol, that pistol short sound seen in femoral
Hmm. Heard.
artery.
Yeah.
Straub sign.
Okay. Otherwise called as a drop sign that you hear with your stethoscope placed over the
Yes,
femoral
ma'am.
artery.
Okay, ma'am.
Okay. What else you hear from the femoral artery? Some murmur.
Femoral, yes, ma'am. Femoral artery,
So when you press it proximally, you
uh,
get a systolic murmur. And
systolic, ma'am.
distally, when you press the what do you get? Distally. What sign is
Uh, that is Durosius.
Durosius murmur and the Durosius sign you get. Okay, okay, ma'am. And continue.
Blood pressure is 140 by 60 mmHg, which is
Uh,
wide pulse pressure
how
measured
much
in
is that?
left up.
How much is that? Yeah, it's wide. How much?
Ma'am,
What is the pulse pressure difference?
pulse pressure difference 80, ma'am.
Yeah. Better you mention that. No? That's a wide pulse pressure difference of 8. Okay.
Okay, ma'am.
Then
Then respiratory rate, which
enough.
is 20.
Enough. In your case, where else you want to measure your BP? You were telling about some sign.
Yes, ma'am.
Ah,
Ma'am, Hill sign
yeah. You have to
measure in the lower
measure
limb.
lower limb also. So that
Okay,
difference is important. So how that
okay.
how it will help you? What is that actually? What is Hill sign?
Ma'am, difference between the systolic blood pressure in the lower limb and the upper limb, which exceeds more than 20 mmHg.
Okay, normal difference is 20. If it's going to be more
Yes,
than
ma'am.
20,
It is Hill sign.
okay. So what is the inference from Hill sign? It will help you to. determine the severity of regurgitation lesion.
Yes,
So
ma'am.
whether even without a echo, you can
Find out
find
the
out.
inside.
Okay. How it 20 to 40, 40 to 60, and more than 60.
Okay.
You have to have a word, add-on word here. So especially in the case of this aortic incompetence of presenting, you have to measure the lower
Lower
BP,
level. Okay, ma'am.
and tell about the hill sign also.
Okay. Okay, ma'am.
Right? Coming to,
And then respiratory rate, which is 24 per minute,
is
and
it
it is
normal?
regular.
Is it normal? Rate is normal.
No, ma'am. It's higher.
You are examining the patient at rest. You told me that NICA grade is 2. So which is,
Yes.
you should be comfortable without any tachypnea at rest. Yeah. So now his respiratory rate is increased. So
Yes,
what do
ma'am.
you say? Either you commit the grade as 3 or 4 in your
Okay, ma'am.
history. Or simultaneously change this respiratory rate as a normal flow, whatever it is.
Okay, ma'am.
Okay? Regular
Then
thoracoabdomen.
thoracoabdomen. Then temperature is afebrile. No elevation of JVP. Hepatojugular reflex absent. And then CVS
Actually, this
examination.
can be mentioned like hepatocellular reflex. You see, whenever JVP is elevated, no, when you don't find elevation of JVP, you need not commit. Okay.
Okay, ma'am.
Mm. Okay. Then,
Ma'am, ma'am,
yeah,
in older individuals, in older males, the respiration type would be thoracoabdominal or abdominal thoracic, ma'am.
older individuals.
Uh, the respiration type, would it be abdominothoracic or thoracoabdominal?
It's associated with some other abnormalities. It can be abdominothoracic also. It's highly variable and it's like not very clinically significant.
Ma'am, but normally in males, isn't it abdominothoracic, ma'am?
Yeah, you get.
But it can be thoracoabdominal,
Yeah, when any other system is involved, when any other pathology is there, it can be altered. No?
thoracoabdominal. Okay.
Yeah.
Shall I proceed, ma'am?
Yes, ma'am.
CVS examination and inspection. Chest wall appears to be symmetrical. Trachea appears to be in midline. Apical impulse visualized at left sixth intercostal space, which is 1.5 centimeter lateral to midclavicular line, and no venous engorgement. Precordial bulge, sinuses or scars. Suprasternal pulsation is seen.
Okay. So, apical impulse you find in only one space, or it's in 2 or 3 spaces.
In one space only.
Mm. In hyperdynamic apical impulse, how it will be?
Hyperdynamic.
Mostly, it's not localized to a single space.
Okay.
It can be in the more than one space.
Okay.
There is suprasternal pulsations. Okay.
So,
Then, continue.
palpation, trachea confirmed to be in midline. Hyperdynamic apical impulse felt at sixth intercostal space, which is 1.5 centimeter lateral to midclavicular line. Suprasternal pulsation and hepatic pulsations felt. No thrill and no parasternal heat.
Okay.
and percussion. Right and left borders of the heart are percussed and found to be within normal limits.
Okay, yeah. Within normal limits. Left, where you said.
Yes, ma'am. No, right, left will be not within the normal limits.
It's better not to comment now. Okay. Just right and
Okay,
left borders of the heart are focused. And left is
okay,
being
ma'am.
confirmed with your palpatory finding. That's what.
Okay, ma'am.
Okay.
Then auscultation, mitral area S1 and S2 heard, normal intensity, aortic area S1 S2 heard, which is high pitched decrescendo ejection diastolic murmur heard with diaphragm of stethoscope with patient leaning forwards and breath hold and expiration. Pulmonary area S1 S2 heard normal intensity, and tricuspid area S1 and S2 heard with normal intensity.
Okay.
And
Anything
other
else you want to
systems,
mention in the aortic area?
tick area,
Because since you are presenting a cardiovascular case, anything you want to add in auscultation?
A2 may not be heard now.
May not be heard or it can be stopped. Then,
Yes, ma'am. Then yes, 4 may be present.
okay. Then,
Then
any other add-on sound you want to have? Take it as a negative history? No.
negative history.
Negative finding. I didn't see. I didn't heard.
No, ma'am.
Okay. So the murmur was only localized to your aortic area.
Yes,
This
ma'am.
murmur was not heard in any other areas, and all
Radiation.
other.
Radiation.
Mm. In no other murmur is heard. Only a EDM is heard in the aortic area. And what else? Or can you get any other murmur in the case of aortic regurgitation?
Ma'am,
What are other murmurs?
Austin Flint murmur.
Okay, where is heard?
Ma'am, it is heard in the anterior leaflet of the mitral wall
And it is produced because of the
because of the
regurgitant
regurgitant blood,
jet. Yeah, it strikes the causes
mitral
fluttering of the left anterior mitral
mitral
leaflet and causes a
vibration.
okay. Where it is heard? Austin Flint murmur.
It is
What is the quality of the murmur? What is that murmur? It's a
um,
systolic,
uh,
diastolic.
diastolic murmur, mid diastolic murmur.
Okay, it's a diastolic murmur that is heard in the mitral area. Okay.
Yes.
Then what else can you hear? This aortic regurgitation lesions is a
Then uh, that
high
high
output.
pitched,
Ah,
yes, ma'am. High pitched decrescendo diastolic murmur heard.
okay. Oh,
Can I
is the
proceed?
murmur this is short or long? How that is
Um, uh,
significant? A
that
short
murmur
murmur.
is
It's going to be a very short murmur.
short.
Ah, what is the significance of that duration of the murmur?
Indicates
Um, uh,
severity.
Yes, very good. It indicates severity. Where do you get a short murmur? in acute conditions. When the aortic regurgitation is acute, case of any
Okay.
traumatic rupture or rupture because of infective endocarditis or a rheumatic fever, acute rheumatic fever causing aortic regurgitation. In the case of acute conditions, you can have a short.
Okay.
Okay. Any other murmur in the aortic area itself? These are high cardiac output states. What happens? The left ventricle receives blood from the how's the ventricle?
Um, hyper.
Yeah. See? It has to accommodate the blood from the recursion jet also, and
Regurgitant. Yes,
uh,
ma'am.
it gets the blood from your atrium also. So
Atrium
how?
also.
Yeah. So how will be the left ventricle?
Left ventricular hypertrophy.
Hypertrophy in the form of not exactly. It's a what type of hypertrophy? It's a pressure or a volume?
Pressure hyper.
Pressure.
No, volume hypertrophy.
Volume. Yeah. So in order to understand this, it becomes dilated. So amount of
Okay.
blood that it has to pump is more. So
Okay.
there can be a functional stenotic murmur
Okay.
across the aortic valve whenever it is pumping. So it can you can also have a functional functional uh, functional stenotic murmur of the aortic valve.
Yes.
How it
Okay.
will be? How it will be?
Mm,
Similar to a aortic stenosis,
aortic
but it's
stenosis.
not a
Okay.
true. It's only a functional murmur.
Functional murmur.
Then what type of murmur you get in stenotic lesion, aortic stenosis? What type of murmur you get?
Aortic stenosis. Ma'am.
Hmm.
Uh, Aortic stenosis. Ejection systolic murmur.
So
Then
that can also be heard
yes, ma'am.
in the case of severe.
Yes, ma'am.
So this aortic regurgitation murmur along with this stenotic murmur also, the functional stenotic murmur, how it will be?
We
Can mimic a, so you have a diastolic murmur also, you have a systolic murmur
systolic
also
murmur.
here. Okay.
Yes, ma'am.
Sometimes it can mimic a
Can
continuous murmur, but uh, you have a murmur in the systole and diastole also.
okay.
Okay?
Then uh, seagull murmur is seen.
Hmm. Where do you get?
And don't know.
Severe aortic
Whole
stenosis.
severe?
Perforated leaflet, ma'am.
Uh, it becomes a musical quality.
Musical quality.
Sometimes this murmur can radiate up to the
Carotids,
carotids. Yeah, can be radiated, but the diastole murmur radiating to the apex.
apex.
What is it called? See, it's not radiated, or the same murmur you can hear in the apex and the axilla.
Carrot.
What
Gallo,
it's called a cold cecil murmur.
huh?
Okay.
Cold cecil murmur. COLECCIL.
Whole
Okay, ma'am.
system.
Aortic murmur that is heard in the atrial.
Okay.
Okay, ma. Then you want to go to the other systems.
Yes, ma'am. Then RS, normal vesicular breath sounds heard, no nasal crepitations. Abdomen, hepatic pulsation seen, no organomegaly, and no free fluid. And CNS, no focal neurological deficits.
Okay.
Diagnosis, a case of acquired disease of senile degenerative calcific aortic valve disease with aortic regurgitation. The patient is in sinus rhythm, not in failure, with no signs of pulmonary hypertension and without endocarditis complications.
Without any features of endocarditis.
Endocarditis complications.
So how do you say your justification for this?
Uh, it is not acute, man. It is chronic nature.
Okay. Patient has been asymptomatic without any
Patient
features of. Till he is around 70 to 73 years. He has been
74
very,
years.
yeah, very, very normal without any comorbid illness. He is able to do his. Even actually, you have to tell about the work.
Work.
Yeah? What work his occupation you have to add on. That is also important. So
Okay.
already a person who is in the who will come to
Okay.
you earlier. Person with a sedentary lifestyle or actively working person. He will be noticing his limitations and he's actively moving. So the person with a sedentary lifestyle is mostly at rest
Yes,
will not come to you early. So
yes.
as an active working, hard working laborer,
Only he will come first.
yeah, he will be because he becomes symptomatic.
Yes, ma'am.
Yeah. So he will seek for the advice of the doctor, something is happening to me.
Okay.
So occupation history is important. I have to mention about the occupation.
Okay.
So he has been no history of congenital heart disease running in the family or inherited heart disease, thyroid expression, nothing is there. So he has come to this age and now only he is symptomatic. So you want to see this degenerative.
Okay.
Okay. Then why do you say it's a calcific? Why do you want to say calcific? So if you want to say a calcific here, what else you should have added in the hospital the findings?
Uh,
Soft tattoo.
Hmm. You should have added that. Okay. Simply you can say it's an aortic valve. Or if you want to add on here, you have to add a soft S2, soft A2 there. Okay. Then it's aortic valve in the form of aortic regurgitation.
regurgitation.
So why do you say it's only aortic regurgitation? Few justifications. You came to a conclusion. What made you to, or what helped you to diagnose?
Because
The
of
case
the
of aortic regurgitation alone and not a stenotic lesion.
because mid diastolic member is seen.
You start from your, you have to start from your history itself. You can start, no?
Stream.
Start from the history itself. It's only an regurgitation lesion.
Signs of left heart failure was not present.
May not be, no, from the history. Do not try to rule out from the history. Obstructive lesions generally present you with syncope.
Okay.
Is
Syncope. No presence of syncope.
regurgitation. Regurgitation lesions mostly have high output states and they present you earlier with palpitations.
Okay.
Whatever is chest pain, as chest pain also is late.
Yes, ma'am.
Where an obstructive lesion you get and the cardiac output is itself low, you get a chest pain, exertion, chest pain, exertion, syncope, and breathlessness earlier than in a
And,
regurgitation lesion. Okay. Then
okay.
the patient who didn't have any loss of consciousness. Oh,
No, no, ma'am.
okay. From history. Then,
Then based on examination,
hmm,
that presence of mid diastolic murmur.
now something you said before. You told me all the
Uh,
signs of,
yes, ma'am. Liver pulsation.
even before that, you told me something.
Uh,
Locomotor brake is there, vessel wall is
yes, ma'am.
getting thickened, and
Yes,
your
ma'am.
BP is,
BP is
how much was the BP? 140, 60 with a wide pulse pressure,
wide pulse pressure.
uh, with a kill sign, let's
Hill
say
sign.
maybe more than 60 millimeters. Then,
Yes, ma'am. Also water hammer pulse.
hmm, you saw some suprasternal pulsations. So you can
Yes, ma'am.
club all your findings, whatever you have,
Findings.
yeah, you have to club your findings for your justificate. So see, I have seen all this, which made me decide only going to be a regurgitation lesion involving only the aortic valve.
Okay.
Then,
Then
so
uh,
aortic regurgitation. Then what you said?
um,
You said
the patient is in sinus rhythm.
sinus rhythm.
Yes,
Okay,
ma'am.
not in failure. Okay,
Yes, ma'am.
okay. Proceed. So how do you want to investigate
Then
this patient?
chest X-ray is done, ma'am.
Hmm. Firstly,
Then
what will they complete? ECG.
yes, ma'am. ECG.
Hmm.
Uh,
What do you find?
the left ventricle enlargement
Okay.
due to volume overload.
Okay.
Then in chest X-ray, we can see uh, gross cardiomegaly.
Cardiomegaly. So whenever
Yes,
you have patients with cardiomegaly,
yes, ma'am.
sometimes patients may present you with some conduction defects or ectopics.
Okay,
So
okay,
very common in a dilated DCM, dilated cardiomyopathies, or whenever there is a volume dilatation.
okay.
So
Then
least you have to find the any other rhythm disease there.
okay,
Ectopics. You want to rule out. Then chest X-ray, as you told, it's a cardiomegaly.
yes, ma'am.
What else can you see?
Chest X-ray, whether there is any calcification,
Where do you find calcifications? Where
uh,
all can
in
you get?
the aortic wall,
Hmm.
or the ascending aorta,
Okay. Aortic valve, root of the aorta,
root
arch.
of aorta,
Yeah,
arch.
everything can get calcified.
Yes, ma'am.
What do you see here? Prominent
Ma'am?
aortic knuckle. Prominent aortic knuckle and atherosclerosis. When you say
Okay.
senile degenerative, no, these all will help you in diagnosis. Then, yeah, X-ray, ECG. What else?
Then echocardiogram.
Okay.
Then
What all see? What all you will be able to see in echo?
the dilated left ventricle.
Okay.
Uh,
So you will be seeing all the four chambers
yes, ma'am.
and dilated left ventricle. Then,
Then it will also be hyperdynamic.
okay, the valve you will see. So you will measure
Wall.
the gradients. Hmm?
Yes, ma'am.
Pressure gradients. How is the? You can.
So,
It's a dynamic, no? So you'll be able to
yes, ma'am.
see how the aortic valve is getting opposed, or it's a degenerative valve, or there are any calcifications. You'll be able to make out. So
Okay,
it was very important. Yeah. Then
okay. Then cardiac CT, MRI.
cardiac CT MRI. Why? You told your patient is in very is not very symptomatic. No, I mean,
Yes,
there's no signs of failure. There's no signs for infective endocarditis. Why do you want to
yes,
go for cardiac MRI? I think you can avoid all these. Huh? You just
Okay.
present whatever relevant to your case.
Okay.
That is more than enough. And justify you because I don't have any other. See, when you have patients with infective endocarditis, you don't see the vegetations clearly. Then you can plan for maybe
Okay.
and in but not in like when you have presented a patient here. So
Oh,
what else?
okay. Mm. Then
With echo itself, you can do the color Doppler
yes, ma'am.
to detect the severity.
To s- this
Okay, the color, how much is the regurgitated jet to this, be able to
okay.
find out. Then for this patient, ma, who he's around 74 years, what
Yes, ma'am.
what do you think can be there with this patient?
Mm.
Can he have a associated coronary artery disease, CAD?
Yes. Yes, ma'am.
So maybe you are justified to do a coronary angiogram,
Okay, ma'am.
cardiac
For my
first
angiography.
angiogram, yeah, to just to find out how is your coronaries. If he has any
Art.
custom, if
Okay.
this patient needs surgery, CAD can be addressed at the same time. So that
Okay.
can be used as an investigation here. Then you have investigated. Then how will you treat? Treatment is
Treatment, ma'am. Treatment is medically we can
mm,
give vasodilators in selective
mm,
cases, ma'am,
mm,
and administration of sodium nitroprusside,
mm.
and also loop diuretics like furosemide in acute emergency.
So whenever seeing failure, you want to use a loop diuretics.
Loop
Okay.
diuretics
Okay. You want to these regurgitation lesions. You want to keep your systolic BP under control.
under
So
control. Yes.
you will be you can use a vasodilator also.
Okay.
You have BP is 140,
140 bar 60, ma'am.
60.
Yes, ma'am.
Okay.
Then
Then,
surgically aortic
mm,
wall replacement can be done,
mm,
and percutaneous wall replacement can be done, and transcatheter aortic wall replacement can be done.
okay. So these have come. So when you ask the patient for surgery, when do you refer the patient for a surgical management?
And in
And
case of
where all you yeah.
yes, ma'am. In case of acute AR, surgery should be done within 1 year, ma'am.
And the patient is in presenting you with severe failure. So acute AR patient will not be very asymptomatic. They'll be in failure.
Okay.
So then you have to correct the failure and take up surgery as early as possible. Then
Then in
how
case
long
of
can you
severe AR, even though it's symptomatic or asymptomatic, if it becomes severe, surgery should be done.
surgery will be
Whereas,
considered?
yes, ma'am. Whereas in mild or moderate AR, without any symptoms in asymptomatic stage, through medications, we can
You
prolong.
can manage. So you
Yes,
have
ma'am.
to ask the patient to come for a periodic follow-up and you have to do an
Okay, ma'am.
echo every year to find the uh, left ventricle end diastolic, left ventricle, especially dimensions of the left ventricle,
Okay, ma'am.
systolic, cervical dimensions. How it's important. If it's more than 55 millimeters, then you see can refer the patient for a surgery. It's time you have to
Surgery.
refer the patient for surgery.
Okay.
And EF is around 50. So then the left ventricle is starting to fail. That time you have to refer the patient for surgery.
Surgery.
And have a percutaneous and transcatheter aortic valve replacements have come now.
Okay.
Thank you.
Okay. Thank you.
Nice presentation, Pa, but few things you please alter, no? so that
Sure, ma'am. I'll alter
you will
this.
not contradict, yeah, you will not contradict your own
Okay, ma'am.
presentations.
Thank you.
Any doubts, ma'am? And,
Ma'am, one thing, percutaneous and transcatheter, they're different, ma'am, valve replacement.
yeah, it's
Yes.
not an uh, it's not an open heart surgery.
They're both
Percut-
different from each other, ma'am.
which one, ma'am?
Percutaneous and transcatheter valve replacement.
I think they use two-way approach, ma'am. Here, here,
Two, two-way approach, ma'am.
trans catheter is only a true catheter that you have a loaded valve that will go and sit in the aortic place, and then it will expand.
Oh, yes, ma'am.
Trans catheter is only
And
you
percutaneous.
canalize via the either with the femoral or the femoral is femoral route we have established. Entry is established through femoral route.
And
It's purely your at, at cathedral based.
percutaneous is two-way, ma'am.
Hmm.
Okay, ma'am.
Okay, then to finish the class just before, so can you tell me some common examples or causes for AR, acute AR and chronic AR?
Rheumatic heart, acute AR, infective endocarditis, ma'am.
Hmm.
Dissection of aorta, ma'am.
Hmm. Aortic dissection,
Syphilis, ma'am.
traumatic.
Traumatic. Prostatic valve dysfunction.
Okay, for chronic,
Rheumatic fever.
hmm. Rheumatic fever, chronic, rheumatic
Sorry,
heart
rheumatic
disease
heart
following,
disease. Yes, ma'am.
yeah, following rheumatic heart disease. So
And
in that case, mostly mitral valve will also be involved
involved.
confirm, concomitantly. Okay, then
Connective tissue disorders.
hmm. What are the connective tissue disorders?
Ehlers-Danlos, Marfan.
Marfan's, then
Some
Syphilis,
drugs.
ankylosing
syphilis.
spondylitis.
Yeah.
Some drugs like fenfluramine.
Then what they specifically cause all these? It's a valve problem or a
Valve problem.
valve problem or the root dilatation. What is the pathology mainly here in phantom tissue disorders? Main pathology will be the aortic root that is getting dilated and the aortic valve gets prolapsed.
Okay.
There's a lack of support causes the valve to allow regurgitation. So it's mainly the root that is getting dilated and the pathology is there. So if it's going to, when you are going to try for a valve replacement in the case of Marfan's, what do you want to address? The aortic dilatation also you have to address. Then only the valve will be able to sit in that position. The pathology is in the aortic root. So what will be the clinical features or auscultative findings in a root dilatation patient? Patient with syphilis, patient with Marfan's, or ankylosing spondylitis with undergoing disorders. Where do you find the murmur more or findings? How it will be?
Murmur over left lower sternal border, ma'am.
Okay. These where will be the root? It'll go more towards the, if it's going to be pertinent only to the valve, that the valve, only the valve is a problem, then you can hear it in the aortic area or the neo-aortic area, the left third intercostal space. It's going to be a root dilatation is a problem, then where will you hear? Where will you see? You see pulsations, you can feel the thrill, where? More to the right side of the sternum also. And suprasternal pulsations will be there. Specific murmur you hear in specific sounds that you hear in syphilis. How will be the,
Timbre quality, ma'am.
okay, will be very loud. So unless the, I mean, as you said in the soft calcific aortic valve, you will be very soft. Here you will be, it will be very loud. Okay. Then again, anything else? Shall we wind the class?
Yes, ma'am.
Thank you.
Thank you, ma'am.
Thank you, ma'am.
போயிட்டாங்களா?